Hello, welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this module is another part of the series on value-based healthcare entitled Clinical Team Multiplication. This module is targeted to Level 4 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, please reference the Replete resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows: to outline the different types of non-physician providers used by radiology groups to enhance the efficiency and quality of their practices and make the work of the radiologists more productive and meaningful. To describe the licensing and training requirements for each of these groups of healthcare professionals, and to identify ways to utilize these clinical providers in various types of radiology practice scenarios. Here are two recent and comprehensive review articles for those who would like to learn more about the topics in this module. Disruptive innovation is a term we hear a lot about in the rapidly evolving world of business. Coined by Harvard Business School professor Clayton Christensen, it's a process by which a product or service takes root initially in simple applications at the bottom of a market and then relentlessly moves up the market, eventually displacing established competitors. The key points here are that markets are always changing, and that incumbents can't get complacent, thinking that just because they have the market cornered today, that it will always stay that way. The simple way that I think about this is this: to get into a market, you don't necessarily need to be better. You just need to be good enough, at least with regard to quality, as long as you can come in at a cheaper price and/or a more convenient, customer-friendly manner. You see listed here some industries which have been disrupted over the last couple decades. The one that most of us in healthcare are familiar with is the explosion of retail medical clinics, like CVS Minute Clinics, which are now all across my town. You wouldn't want to go to one of these if you were in a car wreck or having crushing chest pain. But what if you had a fever and terrible sore throat, and you thought that it might be strep? And it was on a holiday weekend, so that you knew that your primary care physician wouldn't be available for 3 days, and the ER waiting rooms would be packed. When our kids were away in college, I routinely encouraged them to use urgent care clinics, just like these, for such common ailments. The centers were convenient, and by the way, covered by my insurance, and the quality for these encounters was just fine. Of note, every one that we have used has been staffed by non-physician providers, and usually nurse practitioners. Back almost 2 decades ago, Christensen predicted that non-physician providers would soon disrupt the healthcare ecosystem, and he was right. Here's what he said: nurse practitioners are capable of treating many ailments that used to require a physician's care. That's a bit scary for many physicians, particularly family practitioners. But he also acknowledged that the just good enough threshold meant that they'd need more help in doing their jobs than more comprehensively trained physicians. And specifically, they'll need diagnostic and therapeutic advances to allow those nurse practitioners to treat diseases that used to require a physician's care. And diagnostic and therapeutic advances are what we do as radiologists, so this is potentially very good for us as a specialty. And it's not surprising then that non-physician providers have really caught on like wildfire. Here's a table from a few years ago from Merritt Hawkins, one of the largest healthcare recruiting companies in the nation. And look at what happened to nurse practitioners and physician assistants over just a 5-year period. They went from not even being on the top 20 list of most sought-after medical professionals to now collectively ranking 4th on that list. And so the marketplace reality is that they're here, and that they are here to stay. I don't think that's going to change. The Association of American Medical Colleges, for example, is predicting a pretty dire physician shortage in just a decade or two. They believe that we aren't keeping pace, training enough physicians to care for our growing and aging population. And so they, like others, are predicting a huge and important gap to fill. These graphs show how both the nurse practitioner and physician assistant communities are growing. Urgent care, primary care, And increasingly, specialty care practices are embracing these healthcare professionals and helping them deliver high-quality and timely medical care. And those opportunities exist for radiology practices as well. Remember, these modules in Level 4 of Replete are focused on making us, as radiologists, as efficient and effective as we can be. Using non-physician providers is just one type of out-of-the-box redesign of our practice workflows to do just that, as we talked about briefly in the cost reduction module back in Level 2. But in order to do that, we need to take our eyes off of the myopically tracking physician RVUs and focus instead on our practices more broadly. This isn't a new concept, but rather one that has gradually gotten a lot of traction. Here are some slides from a talk that I gave way back in 2004, when my then private practice was one of the first in the country to utilize both radiologist assistants, you see at the top a photo of our 2 RAs at the time, in our diagnostic radiology practice. We additionally hired physician assistants. You see in a photo at the bottom of Ben Carr and Steve Vassis in our interventional radiology clinic. And interestingly, I've personally come a bit full circle in my career, since the academic department that first put this topic into print was Emory University, where I now practice. In Emory's large, multi-site academic radiology department, we have a team of really terrific non-physician providers, and mostly nurse practitioners, who really enhance our practice in many of the ways that I'll be discussing. What are non-physician providers? I've used the term several times already, so it's time to define it. When you hear the term non-physician provider in radiology, think about 3 separate groups of professionals that you see listed here: radiologist assistants, physician assistants, and nurse practitioners. We'll talk about each of them individually, but let me first provide you a bit of context into who they are, which I think will be particularly useful when we talk about billing for their services in a compliance module down the road in Level 5. Broadly, when we talk about non-physician providers in radiology, we're talking about 3 different groups of individuals: technologists, physician assistants, and nurses. Most technologists are the individuals we all know of in a traditional sense as valuable team members in our practices. But some of them have gone through additional training as radiologist assistants, and we'll be talking about those individuals today. The same holds true for nurses. Of that group, it will only be those who have pursued additional education, training, and licensure as nurse practitioners that we'll be focusing on in this module. And it is only those 2 groups, along with physician assistants, that will be the focus of this module. Of all the groups you see listed here, only the 3 of these have, for lack of a better term, physician extender roles, meaning that they can do some work traditionally done by physicians. Radiologist assistants, sometimes referred to as RRAs or RPAs, as we'll talk about shortly, are a group of specially trained technologists who can do more than just work as techs in the traditional sense. Don't get them confused, though, with PAs, who are trained via a completely different pathway, which is sort of like medical school light. The initials may be similar, RA or RPA or PA, but the skill sets and associated scope of practice and billing issues are quite different. And the individuals used most in our practices, and in many other practices, are nurse practitioners. These are nurses who have taken considerable extra education and training, some now practicing with doctorate-level degrees. For reference, here are the most current numbers available about how many of each of these groups of professionals are currently in the U.S. workforce. There are nearly 250,000 nurse practitioners employed in a variety of different practice scenarios, about 100,000 physician assistants, but only 600 radiologist assistants. And so while we in radiology focus a lot on scenarios where RAs can and cannot work in our practices, I think it is useful to have a reference that there aren't that many currently working in radiology groups. Let's talk about each of these groups one at a time. There are 2 pathways by which one can become an RA. The earliest pathway was through a program at Weber State University in Utah, which many years ago set up an RPA program on its own, Radiology Practitioner Assistant. More recently, with input from the American College of Radiology and the American Registry of Radiological Technologists, about a half-dozen programs across the country have established RA curricula that lead to certification as an RRA, Registered Radiologist Assistant. RA, RRA, and RPA are largely now synonymous, and opportunities exist for cross-credentialing. One thing of importance to note is that although these individuals are highly trained and certified by the ARRT in their designated areas of practice, Medicare does not currently recognize RAs as QHPs, qualified healthcare professionals, for billing purposes. That's something we'll talk about a bit more in an upcoming compliance module. What that means is that it substantially limits how you can use these professionals in your individual practice. The ACR and ARRT continue to lobby CMS to reconsider that designation, but until that point, it is the law of the land. It's important to note, though, that even though you can't bill for their services, these individuals can and do provide substantial value in many radiology practices and help radiologists become much more productive, efficient, and impactful in their day-to-day activities. Although the initials might sound similar, PA is just one letter away from RA. Physician assistants are a group of professionals very distinct from radiologist assistants. Almost all are trained through a direct pathway for PA education that leads to a variety of typically master's level degrees that you see listed here. And almost all states recognize PAs in one form or another as independent or quasi-independent healthcare practitioners. There are currently no formal training programs for PAs in radiology. This is a big opportunity for the radiology community and something our group, like a few others, is beginning to explore. What that means is that most are thus trained in an ad hoc manner by their individual radiology practices. I'm intentionally focusing on the Medicare designation for each of these professional groups because it is very important that we'll talk about in an upcoming compliance module. Unlike RAs, PAs are recognized by CMS as qualified healthcare practitioners. That means that they're able to bill for at least some of their services. And that regulatory point will in many ways dictate how you can use these individuals in your practice to add value in ways that are both billable and non-billable. Unlike PAs, who are trained pretty much from the get-go as PAs in an educational paradigm that is in many ways similar to the one that we as physicians have been trained, NPs are first trained as nurses in traditional nursing programs and then go on to receive additional training as nurse practitioners. These programs traditionally led to Masters of Science in Nursing or similar degrees, but many programs are now conferring doctorate-level degrees, usually the Doctorate of Nursing Practice. As with PAs, most states recognize nurse practitioners as independent or quasi-independent practitioners, and that gives them a lot of latitude in their scope of practice. But just as with PAs, no formal established radiology residencies or other similar radiology-specific training programs exist. So most are trained in radiology in an ad hoc manner, often by the practices that employ them. That's what we do in our practice here at Emory and in the private practice environments in which I have previously worked. Once again, I'll highlight this professional group's Medicare status. Like PAs, nurse practitioners are recognized by Medicare as QHPs, qualified healthcare professionals. That means that they can bill for at least some of their services. Something again which will influence how you can use them in your practice to add value. Again, this is something we'll talk about in a good bit more detail in an upcoming compliance module in Level 5. There are a number of roles that non-physician providers can play in your practice to add value and help your radiologist practice more often at the tops of their licenses. These roles are all unique and different, and so it's probably best to break these down separately into scenarios involving diagnostic radiology and interventional radiology, because they are quite different. Because diagnostic radiology interpretations require the skills of a residency or fellowship-trained radiologist, there are few, if any, roles that non-physician providers can play in rendering billable services. That said, they can provide a large number of services that help radiologists provide their billable services more efficiently and in a more patient-centered manner. Remember, just because some work isn't billable, that doesn't mean it's not valuable. Remember back to the Level 2 module on costs where I showed you the hypothetical practice that hired a reading room coordinator and a nurse practitioner and essentially reclaimed 2 radiologists' worth of physician work. That's what we're talking about here. There are some roles that have been described in the literature for RAs and PAs providing interpretation services and rendering diagnostic fluoroscopy services. But I won't spend time on these because the scenarios in which these can be billed are narrow at best. We'll focus instead on value-added services, and particularly care coordination. The best roles for non-physician providers in diagnostic radiology, I believe, is as care coordinators. These are ideal roles for RAs, who essentially function as clinically expert super technologists, but cannot otherwise bill for their services. These individuals can help with utilization management and triage, helping referring physicians order and coordinate the right tests for their patients. And they can be very helpful in coordinating patient follow-up, something our practice, like others, is using them for in our CT lung cancer screening program. Dr. Syed Zaidi from Ohio wrote in the JCR in 2015 about how he used RAs to enhance his hospital-based practice, particularly in light of helping to rapidly communicate unexpected findings and get those patients scheduled for biopsies or other diagnostic tests in an expeditious manner. By doing so, they reduced hospital length of stay, something of considerable value to the patients, of course, but also, as you remember back from prior modules on bundle payments, to Dr. Zaidi's hospital administration, something that positioned his group in a very favorable light. The opportunities for non-physician providers to add value in an interventional radiology practice are even greater. In those scenarios, RAs, NPs, and PAs can all serve in care coordination roles. But only NPs and PAs can bill for services or write orders or prescriptions and do H&P examinations. And so these are the individuals used much more commonly in interventional radiology settings. The opportunities for NPs and PAs to enhance the quality and efficiency of an interventional radiology practice fit largely into two categories: non-procedural clinical care and procedural services. Let's discuss each of these individually. When we talk about clinical services in interventional radiology, we're typically talking about non-procedural services of evaluating and managing patients, doing H&Ps, coordinating follow-up care, writing and refilling prescriptions, and the like. Nurse practitioners and PAs can capably fulfill non-procedural clinical duties vital to the day-to-day function of a procedural-oriented diagnostic radiology or interventional radiology service. Yes, only a limited number of these services are independently billable, something that I think radiologists tend to focus on a bit too much when they're doing their hiring pro formas. And so I would encourage you to not underestimate the huge value that those non-billable services, like doing H&Ps, moderate sedation evaluations, and discharge reconciliations, bring to your practice in terms of keeping your physicians practicing at the tops of their licenses, doing cases, and interpreting related diagnostic imaging studies. You see from this intentionally provocative title of an old blog of mine that the issue of letting NPs and PAs do and bill for minor procedures has sometimes been controversial. I'm a big fan, however, of using these dedicated professionals, assuming that they're adequately trained and supervised for many minor procedural services. We'll talk more about billing in a future module, but NPs and PAs get paid at 85% of the Medicare physician fee schedule for the services they rendered. Not a bad deal, given that they often cost your practice anywhere from a quarter to a half of what you have to pay a radiologist. And data are emerging to indicate that in a number of settings where radiologists commonly perform services, for example, paracentesis, non-targeted medical liver biopsies, and venous access procedure, that the clinical outcomes of non-physician providers are similar to those of practicing radiologists. And as you can see here in this editorial in JAMA Internal Medicine to an article of ours back in 2014, the goal here is really right-sizing our workforce and matching the right work to the right healthcare professional. Non-physician providers can complement your work as a radiologist in many ways. By and large, radiology practices across the United States have embraced their nurse practitioners and physician assistants in performing a variety of minor procedural services. Here's a figure from a paper of ours looking at who is placing temporary central lines in Medicare beneficiaries. Note in blue that radiologists have overtaken surgeons as the dominant physician specialists. But note as well in orange that the growth slope of non-physician providers is faster than any other specialty. These individuals now perform a growing share of billable venous access procedures all across the country. If you look here at the list of other procedures being performed by non-physician providers in radiology practices, you'll see some amazing growth in non-vascular procedures as well. Nurse practitioners and PAs together now perform over 10% of all paracentesis procedures in Medicare beneficiaries and 5% of all thoracentesis procedures. and they are increasingly performing liver and renal biopsies and even abscess drainages. That all stated, some radiology groups are still fighting their hospital credentials committees, trying to get NPs and PAs credentialed to perform these services that they increasingly render all across the nation. As these individuals increasingly perform more procedures and show up with procedural logbooks that sometimes are showing them with more experience than some physicians, I believe it increasingly likely that more and more health systems will accept and credential these providers and permit them to be employed by more and more radiology practices. Ultimately, that will permit radiology practices to expand patient access in an efficient and cost-effective manner. For radiology practices looking to move simply beyond measuring RVUs and thinking more broadly about adding value and making radiologists more effective and relevant, more and more practices will look toward hiring non-physician providers. That said, not all practices are ready to make this leap. Key questions that individual practices will need to address are the following. What are your practice needs? If you're doing, for example, solely teleradiology, perhaps you just need a reading room coordinator. Will they work in your environment? If you're in a health system that hasn't been willing to credential NPs and PAs, you may need to catalyze those conversations. Do you have a physician champion? Hiring and training and credentialing does not happen magically. It requires a good bit of work to navigate the politics and logistics. And if your group is not willing to let folks get away from the work list long enough to take on this important physician leadership role that will ultimately help your practice in the long term, then your efforts are likely to fail. And finally, how will you use a non-physician provider? Depending upon your individual practice needs, you may need individuals who are trained in different ways in order to match your needs to your extended team's expertise. That might mean a combination of RAs and NPs and PAs. In summary, non-physician providers can enhance your practice in many ways. Some of these are financially quantifiable, but many are not. Depending upon your individual practice type and needs, RAs, NPs, and/or PAs may work best for you. As medicine increasingly becomes a team sport, non-physician providers will become more and more relevant as radiology groups seek to optimize their physician performance and offer value to their patients and other practice stakeholders. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the REPLETE initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in REPLETE.